Bismillahirrahmanirrahim. Today we are going to talk about urinary anion gap. Urinary anion gap, this is another monitor or the last monitor of the acid base. To start with, we resorted to study the urinary anion gap when we studied the metabolic acidosis. Metabolic acidosis is divided into two types. That metabolic acidosis is high anion gap and metabolic acidosis was normal anion gap. Metabolic acidosis with high anion gap. Usually there is loss of bicarbonate or decrease in the bicarbonate in both, either with high anion gap or with low normal anion gap. When we come to the high anion gap, the decrease in the bicarbonate is due to reaction with another acid, like that lactic acidosis or ketoacidosis, or fixed acid in case of renal failure. So the bicarbonate some of the bicarbonate is lost in this reaction and converted to carbon dioxide and water, and the salt is formed from the other acid, whether fixed acid or non-fixed acid. And this is the problem. There is no change in the chloride in this case. So the anion gap in this case is increased. No problem for this. But the problem comes from the other one, which is metabolic acidosis with normal anion gap. So there is a decrease in the chloride and the bicarbonate. And this decrease in the bicarbonate, which is responsible for the metabolic acidosis, is usually lost either through the gastrointestinal tract, as in diarrhea, or through the kidney, as in case of renal tubular acidosis. How to differentiate between the two? Whether this normal anion gap, hyperchloremic metabolic acidosis, is it due to the kidney itself or due to diarrhea? This is a question comes. When it came, we resorted to study to solve this problem by studying the urinary anion gap. Before we enter into the urinary anion gap, it's better to say to study that this solution is formed of inorganic substances, and these inorganic substances usually they are formed of cations and anions. The number of cations equal the number of anions. This is electroneutrality. When you look at the cations which are present in the kidney itself are sodium, large amount, potassium, large amount, and a small amount of ammonium, calcium, and magnesium. These are the cations. In front of this, we have the anions. These anions, like chloride, which form, this is the major component of the anions, in addition to bicarbonate, phosphate, and sulfate. This is a very important one. But we have, when you look at this is a sodium can be measured routinely, potassium can be measured routinely, chloride can be measured routinely, but the rest are not routinely measured. So this is hence comes the study of this monitor. We say this is urinary anion gap will be the difference between potassium plus sodium minus chloride. Normally, the normal amount of urine in plasma of urine of sodium in urine it is about 80 millicubic per liter, and that of potassium is 25 millicubic per liter, and the chloride is 100 millicubic per liter. This is the ratio between the two. So the difference between the two is nearly about 5 millicubic plus or minus. This is a small number. Look at this. The renal tubular acidosis, when we study it, we have two types, main types. First, renal tubular acidosis, type 1, which is a distal convoluted tubule problem, and the type 2, which is a proximal convoluted tubules. When you look at the type 1 renal tubular acidosis, which is a distal type here, there's a problem in the hydrogen potassium exchange bump. This is a problem here. This does not function well. So the exchange of hydrogen ion outside to the urine and the potassium entry of potassium in replacement of the hydrogen ion at the exchange in the form to support the electroneutrality. This is extrusion of hydrogen ion, and this is the entry of potassium. This is usually interfered with. It does not work well. This due to either hereditary or acquired problem. So in this case, this means that the correction of the blood or plasma acidemia or acidosis will not be good. So the acidosis of the blood will retain, and its corrections will be difficult. And at the same time, the potassium itself, which is absorbed, is not absorbed well, so it is lost in the urine. So the plasma will suffer hypokalemia, and at the same time the value of potassium in the urine will increase. And from this point we can come to a conclusion in that renal tubular acidosis type 1, which is the distal one, these excessive secretions of potassium in urine. So this means that the sodium, which is normal, chloride, which is normal, plus high potassium, all this will give you a positive differences. So in this case, the difference between for the anion gap will be high positive. This will be more than 5, will be 10, something like that. So there is an increase in the positivity. This is a problem due to increase in the potassium. When you come to the renal tubular acidosis type 1, this is the problem here is proximal. The proximal is the proximal here is this is a type 2. This is a this is type 2, not type 1. So this is a proximal one. The proximal problem is there is here also this disruption or this the deficiency or in the sodium hydrogen exchange pump, in which there is a failure to excrete hydrogen ion. At the same time, there is a failure to absorb sodium. So the sodium bicarbonate itself will be lost. It means that the acidosis of the blood will not be corrected. At the same time, there is loss of sodium bicarbonate. So the sodium in the urine will increase. So when you look at this is renal tuberous number 2. So this in this case is the sodium will increase. No change of potassium, no change of chloride. So the sodium will increase. Increasing sodium, this means that the difference is positive. So in this case, I think it's better when we come to renal tubular acidosis. This is urinary gap. Sodium is high or potassium is high minus normal chloride. This means that this is a positive. But when it comes to diarrhea, there is in case of diarrhea there is a loss of bicarbonate with concomitant retentions of chloride. So the patient is hyperchloremic. Metabolic acidosis due to loss of bicarbonate. But this is a normal anion gap again. In this case, the chloride which is retained is excreted in urine in the form of HCl. When the pH drops below 4.5, the kidney starts to excrete ammonia, and ammonia with HCl will produce ammonium chloride. So the net results in this type of diarrhea, there's increase in ammonium chloride in urine. So the increase in ammonia and an increase in the chloride. This means that when you look at this, this is the chloride has been increased, no change of sodium or potassium. So the difference between the two, sodium plus potassium minus chloride, will be negative because chloride is more than the two. This is due to the presence of ammonium chloride. So chloride has been increased in the form of ammonium chloride. We do not measure ammonia, but we measure chloride, so the difference is negative. So I think to come to a conclusion, urinary anion gap, this is a good one to differentiate between diarrhea, and which is the excessive secretions of ammonium chloride. So the chloride will be more than the sum of sodium and potassium, and this means that it is negative. But in case of renal tubular acidosis, whether it's type 2 or type 1, where the increased excessive secretions of potassium or excessive secretions of sodium in the form of sodium bicarbonate will be more than chloride, so the difference would be positive. So positive urinary anion gap, this means this renal tubular acidosis, and the negative urinary anion gap, this means that it is diarrhea. And thank you.